Welcome to GP Notebook TV. My name's Dr. David Miller-Jones. I'm going to talk about diverticular disease in relation to the NICE guidelines published in November 2019, the NG147. The true prevalence of diverticulosis is difficult to determine. We know that it is age-related and normally is very rare in patients less than 40, although recent data does suggest increasing incidence in this age group. In real terms, patients aged over 65, 65% of them will have some form of diverticulosis. 80 to 85% of people affected will be asymptomatic, and about 10 to 15% will develop intermittent symptoms of their diverticulae. The management and advice we should be offering should be reassuring. The condition is normally asymptomatic and there are no specific treatments that are needed. We should be encouraging a healthy diet, making sure it's balanced with whole grains, fruit and vegetables. There's actually no need to avoid seeds, nuts, popcorn or fruit skins. We should be encouraging an increase in fibre intake, and with the gradual increase in fibre intake we should be also encouraging an increased fluid intake. We should consider bulking laxatives for patients with constipation and also encourage healthy living with exercise and weight loss in those who are overweight. We should suspect diverticular disease in people who have intermittent abdominal bloating, abdominal pain, particularly in the left iliac fossa. A clinical warning is that in some ethnic minorities the pain will be felt in the right iliac fossa. The symptoms unfortunately can overlap with irritable bowel syndrome, colitis and even malignancy. We should not be offering routine antibiotics to these patients, and lifestyle is normally what is required with intermittent bulking laxatives. We should consider simple analgesia, paracetamol, if at all possible, to avoid anti-inflammatory therapies and opioid therapies. We should consider using antispasmodics for abdominal cramps as needed. Sometimes diverticular disease can become complicated and develop into diverticulitis. We should suspect acute diverticulitis in patients who present with abdominal pain of increasing severity where it's localized. If they have fever, if they have a sudden change in bowel habit or rectal bleeding or passage of mucus per rectum. We should examine and find whether there's any evidence of tenderness, distension or guarding. Complications of diverticulitis can result in acute illness and significant morbidity. We should examine the patients looking for abdominal mass, examining for perirectal fullness, which may suggest intra-abdominal abscesses, examining for abdominal rigidity or guarding, which could suggest perforation or peritonitis. Don't forget to look for signs of sepsis, altered mental state, increased respiratory rate, low blood pressure, a tachycardia, low temperature, reduced urine output, and skin discoloration. Ask about fecal urea and also pneumaturia, suggesting fistula formation. Assess for colicky abdominal pain and pain with absolute constipation. Vomiting, distension may suggest intestinal obstruction. In most of our patients, there will be a non-surgical management of diverticulitis. Most of what we will be doing is treating their symptoms, and we should avoid antibiotics if possible. offering simple analgesia, especially paracetamol, and encouraging fluid and diet. If patients are systemically unwell, and certainly if they are immunocompromised, we should consider antibiotics. If patients are significantly unwell, hospitalization and intravenous antibiotics should be used. The antibiotics of choice, our first line, would be co-amoxiclav, 500 milligrams, 125 milligram, 3 times a day for 5 days. Alternative second line would be cefalexin with metronidazole or trimethoprim and metronidazole. All therapies for 5 days. Thank you for listening.